Hi, good evening everyone, and this is Dr. Saumya, Associate Professor of Department of Pediatrics, and I am coming back to you with the third part of my lecture on Wilson's disease, right? So we talked about its etiology, the pathogenesis so far, and what happens to albumin and ceruloplasmin and copper in the bloodstream, and which organs are affected. And we later on moved on to what are the clinical manifestations, the different organs involved, how it presents, and the most important point that I would like to emphasize again from my previous lectures here is that Wilson's disease is highly variable and it can present in any way, and it requires a high index of suspicion, right? And the rule of thumb is anybody who presents, or any child which presents above the age of 5 years with idiopathic onset of liver cirrhosis or liver failure should be worked up for Wilson's disease unless otherwise proved. So how do we diagnose Wilson's disease? So in many centers it is very hard for certain diagnostic tests to be present, but it's not that difficult for the diagnosis of Wilson's disease. It hardly requires a few investigations and they are pretty straightforward. So we are going to talk about a few common tests that are used for Wilson's disease. So it ranges from measuring the serum ceruloplasmin levels and measuring the 24-hour urinary copper excretion levels, followed by MRI of the brain, especially in cases of neurological manifestations, ophthalmic evaluations, which we already discussed, followed by liver biopsy and genetic tests. Right, so let's talk about serum ceruloplasmin. It is typically decreased in patients more commonly with neurological Wilson's disease, but it may be in the low normal range in 50% of patients with active Wilson's liver disease. So all of us know that ceruloplasmin is an acute phase reactant and it can be falsely elevated in cases of acute inflammation. So sometimes it may not be an accurate representative of the true presence of Wilson's disease. So it is neither diagnostic or it is sensitive enough to pick up Wilson's disease. But one thing I'd like to highlight about ceruloplasmin is that if it is low, then there is an indicator that yes, it's probably Wilson's disease. So a low serum ceruloplasmin level is highly suggestive of Wilson's disease and it should be ruled out, especially in cases where there is acute inflammation and it is typically reduced, which is very uncommon, right? So let's move on to 24-hour urinary copper. So this test is performed using a huge glass bottle or any method of collection where for 24 hours the patient is asked to collect the urine inside a bottle and the amount of copper excreted is measured in that, and more than 0.6 micromoles per 24 hours, that is 38 microgram per 24 hours is significant, right? Now sometimes it so happens that our dietary intake of copper is highly unregulated. So copper is present in chocolates, it's present in a lot of sources like nuts, and it can come from various sources. So in the past week before doing this test, if the patient has ingested any of these substances, then it can lead to a falsely elevated level of urinary copper, or the results can be indeterminate, right? So that time what you do is chelate this copper, the copper which is present in the bloodstream, and try to give a challenge, and this copper gets excreted more, and this challenge is done by giving a dose of D-penicillamine, which is a very useful confirmatory test, and more than 25 micromoles per 24 hours is considered diagnostic for Wilson's disease. So 24-hour copper test usually requires a baseline copper to be measured. So there is 1 day of urinary copper to be measured, as well as followed by 1 day of the challenge test, which is supposed to be measured. During this challenge test, 2 doses of D-penicillamine is given according to Nelson, one dose 24 hours apart, or one dose 12 hours apart. Now this requires inpatient admission for the monitoring of the patient's intake of copper as well as the urinary collection. So it might require for the patient to be in with you in the wards for you to perform this test, right? So let's move on to MRI of the brain. MRI is the most important diagnostic tool in patients with neurological presentation, and almost all patients show an MRI abnormality in the basal ganglia. Along with that, there might be non-specific changes in the brain such as diffuse brain atrophy and focal abnormalities in very severe cases. Okay, now I already discussed the ophthalmic evaluation of Wilson's disease using a slit lamp where the KF ring is visible, and since the KF ring is visible to the naked eye also, sometimes you can use this as a diagnostic tool. Before I go on to the liver biopsy, I'd like to mention about ultrasound and ultrasound Doppler of the portal veins. So it is necessary in children who have abnormal AST ALT levels for you to get an ultrasound done. So in the ultrasound, typically we look for the echo texture, the presence of nodules, is there any presence of cirrhosis. Along with that, a portal vein Doppler where the portal vein velocity is measured and what is the condition of collaterals. So this is a must in cases of portal vein hypertension if it has developed in Wilson's disease, because portal hypertension and its onset and management has a completely different line of management, and sometimes Wilson's disease patients can come with life-threatening hematemesis and portal hypertension as the first line of manifestation. So portal hypertension in its diagnosis is important in these cases, right? So the gold standard for diagnosis of Wilson's disease is the hepatic copper content of a liver biopsy specimen, and its content more than 250 microgram per gram or 4 micromoles per gram dry weight is confirmative of Wilson's disease with a sensitivity of 83% and specificity of 98.6%. So even if there is a doubt about sensitivity, it will rule out the disease if you do a liver biopsy and measure the hepatic copper content. Now coming on to genetic testing. So there are various new techniques that have developed for the genetic and molecular studies useful in the last recent years. PCR is done to detect mutations, and H10O669Q mutation is the most common among Wilson's disease, affecting the ATP7B gene with chromosome 13, right? So this is the part about Wilson's disease that I wanted to cover about diagnostic testing, and I'm going to come back in my next video to talk about its management and further prognosis, right? So I'll see you in the next video. Thanks a lot. Have a nice day.